Hi, my name is Lucy Krut, and I'm a student in the Psychiatric and Mental Health Nurse Practitioner program at Duquesne University. And this is my education presentation on food locking for persons with Prader-Willi syndrome. So, what is Prader-Willi syndrome, also called PWS? It is an abnormality of chromosome 15, and characteristics of the syndrome include hypotonia, hypogonadism, intellectual disability in the majority of persons with PWS, abnormal growth and abnormal metabolism, and they also have insatiable hunger due to, well, it's believed that it's due to lack of satiety signals, most likely due to hypothalamic dysfunction. Because of all of these factors, they also suffer from extreme obesity and, without assistance, often extreme severe morbid obesity. I had the pleasure of working with persons with Prader-Willi syndrome over about a 15-year period at the Children's Institute, and one of the recommendations for people with Prader-Willi syndrome, whether they be on an inpatient unit such as where I worked, or living at home, at school, or living in a group home situation, is food locking. And most people, when they hear about locking food away from people, rightly have a negative kind of response. There is a negative connotation of locking food away from people. But there are reasons for these recommendations, which include the fact that people with Prader-Willi syndrome will sometimes eat extreme amounts of food, will sometimes also eat spoiled and or raw foods, and sometimes they will eat pet foods. We had one example of a person who ate the better part of a 5-pound bag of rabbit pellet food, and as a result, he almost lost his life. It's amazing that he actually did survive, but that is a concern. And one of the other reasons is due to their syndrome, they also, in their hypotonia, they also have delayed gastric emptying, which means that when they eat these large quantities of food, they sit in their stomach and they get these very distended, swollen abdomens. And due to their obesity, you wouldn't necessarily notice, as you would with a slimmer person, that they have this, very abnormally full belly. They also have a decreased response to pain, and again, an inability to vomit due to their hypotonia. Now, some people with Prader-Willi syndrome do vomit, but it is rather rare, and again, that is due to their hypotonia. So when you add up these extreme quantities of food, delayed gastric emptying, and a decreased response to pain, you can see where a person with Prader-Willi syndrome could really run into some problems. So you or I, or persons without Prader-Willi syndrome, when we eat too much, we stop because we say, oh, my stomach hurts. Or if we ate enough, it's likely that we would even possibly vomit to kind of relieve some of that pain and pressure. And what happens in persons with Prader-Willi syndrome is that because that food is there and creating such pressure in their stomach, they develop areas of necrosis in their stomachs, and this is what leads to stomach rupture. Often, by the time the person with Prader-Willi syndrome is demonstrating pain, they've already had a stomach rupture. Now, this is a rather rare occurrence in people with Prader-Willi syndrome, the stomach rupturing. However, people with Prader-Willi syndrome who have unlimited access to food will often be extraordinarily morbidly obese, to the point where they're really not mobile. They're bedridden. We will see people as young as 8, 9, 10 years old with type 2 diabetes, obstructive sleep apnea, heart problems, and just an inability to really live their life in any kind of um, good fashion. So the ethical issues with food blocking is that obviously access to food is a basic human right. And when we had our inpatient unit, we had to have special permission from the Department of Public Welfare to have food blocking on our unit. And a lot of times the group homes that serve people with Prader-Willi syndrome have the same issue. So when we talk about food blocking, it's not that they can't have any food. They have a very strict menu because of their hypotonia and their metabolic disturbances. They often require much fewer calories than a person without Prader-Willi syndrome. So it's very important that they do have, 3 meals and a snack every day, and their menus are posted. And there's always, we would always make the recommendation that there's, no confusion whatsoever. Food is not used as a reward. It's not used as a punishment. People with Prader-Willi syndrome should know exactly how much food they're getting, when they're getting it, and we really no deviation from that, because for people with Prader-Willi syndrome, they are very, as you can imagine, food fixated. So we want to make sure that we're not causing them additional distress by adding any kind of uncertainty into when they are getting their food or what kind of food they may be getting. Another ethical issue is that, of course, we see, especially in this country, that there are many people with health issues who overeat and are obese. I myself am overweight. I have type 2 diabetes, and I would not take well to somebody coming in and locking my food up and saying, hey, what you're doing is not healthy for you and it's going to cause you problems. So we're going to lock your food up and only let you eat healthy foods in healthy amounts. So that is an ethical issue. And not to belabor the point, but there are many people without PWS who are not just overweight, but severely morbidly obese and are bedridden. There's the show My 600-Pound Life, and you can see where some of these people have really put themselves in desperately medical situations from overeating, and nobody is going in and locking their food either, or telling them that they can't eat. And people die every day from obesity-related complications. So this is an ethical issue, and one of the things that we did talk about was that while most people with Prader-Willi syndrome do have mild to moderate intellectual disability, there is a small percentage who have low to average IQ. And they are able to understand the issues surrounding the risk with having free access to food. Now, it's been my personal experience, and I believe the personal experience of my colleagues that I've worked with in working with people with Prader-Willi syndrome, that better understanding of these issues does not lead to better ability for the person with Prader-Willi syndrome to make good choices for themselves. Talked a little bit in the previous slide about the fact that, of course, there are people who are overweight and who have diabetes, or maybe a heart condition or other medical issues, who are also overweight, but there is the ability for these people to kind of make the choice to lead a healthier lifestyle and to maintain a diet, even though that might be hard for them. And we all know obesity is an epidemic, so it's not something easily controlled for a person without Prader-Willi syndrome. So for a person with Prader-Willi syndrome, it's all the more difficult for them. And So for someone like me, I have a much better chance of saying, hey, I'm going to really take control of my overeating, get my diabetes under control, eat healthy foods, exercise, and I have a much better chance of actually being able to follow through with that than a person with Prader-Willi syndrome who is not getting any. And again, there is still research out there, but the prevailing kind of idea is that, due to this hypothalamic dysfunction, they're really not getting the satiety signals. So 2 ounces versus 25 ounces of food really doesn't mean anything to a person with Prader-Willi syndrome. So if I, as a person without Prader-Willi syndrome, decide to eat like a high volume of food to fill myself up, that could be a tactic that might work for me that would not work for a person with Prader-Willi syndrome. We also, one of the things, and to say too, the freedom to choose. So there's a lot of body positivity out there today. So do we have a choice to be unhealthy? Do we have a choice to live our lives as obese people or very healthy, fit people? For most people, we do. I don't know of any other cohort of patients. Well, that's not true. There have been a few other syndromes that we have worked with that we have recommended food blocking with. But for the most part, unless it's very unusual or unheard of to lock people's food up and not give them that freedom to choose. And one of the things that we would talk to with patients and with families is the idea of food locking or food restriction versus food security. And when we think of food security, usually we think about the ability to access food or not have enough money for food. But in the context of Prader-Willi syndrome, when we talk about food security as it relates to food locking, it comes back to what I mentioned a bit ago, that there should really be no question for the person with Prader-Willi syndrome living in an environment where food is locked as to when they're getting their meals. Again, it should never be used as a reward or punishment. The menu should be posted, so they should feel very secure in the fact of what food they're getting when they're getting it. Now, interestingly enough, Prader-Willi syndrome is a very anxiety-driven disorder, and we have found that a lot of times when we had people come to our inpatient unit, it was usually for a variety of reasons, but the 2 major reasons were for severe obesity that was really interfering with their life and putting them at risk of dying, and also extreme behavioral issues such as food stealing, aggressive behaviors regarding food, getting in trouble at school for stealing school lunches, getting into garbage cans, that sort of thing. So we have found that whenever we would have them on the unit with food locking and kind of knowing where they're, when they were getting their meals and what they were getting, and having that security of knowing that, it kind of frees them up from, instead of thinking about food all the time and, hey, is mom gonna leave or dad gonna leave the refrigerator unattended and maybe I can sneak in there and get something to eat. If they know that the food is secure and they know they're getting dinner at 5 o'clock and they know what they're getting, they're kind of free to live their lives and engage with their families and engage with their friends and have hobbies. And we found that most of our patients were very happy on our unit, and parents were absolutely shocked because they couldn't believe that their child could have food restriction and be happy. Now, that was true for the majority of our patients, but I will say for some of our patients, this was not the case, and the idea of food locking was extremely difficult for them and upsetting to them, and rightfully so. And going back to the IQ, we did find that people who had normal to average IQs who had Prader-Willi syndrome had a much more difficult time with accepting these restrictions. And this is kind of where the ethical issue and concern comes in. So for a person who does not have intellectual capacity to make a good decision, we feel pretty comfortable saying, hey, we're okay with making this decision to make to keep this person safe and to keep them well nourished and to have them be healthy. But for a person with an average IQ with Prader-Willi syndrome, it becomes a little more complicated because that is still the recommendation. And I do know of, we did have several patients on our unit who did not necessarily want to be there. And of course, sometimes their families had decision-making ability for them, but there were times that we had patients who were able to discharge themselves if they wanted to. We were usually able to talk with them, encourage them to stay, and most of them enjoyed their time with us and they did well. But it does bring into question the ethical values of autonomy and the ability to make these medical decisions for oneself. And I think in order for people to make those decisions, they have to be well informed. And we will talk a little bit about that in the next slide. But there's also the duty of beneficence. So when we're talking about people without decision-making capacity, that food locking recommendation is a little bit easier, but it becomes a little bit tricky with a person with normal IQ who doesn't want food security or food restriction, depending on how you look at it, because we know that without that food restriction or that food security, there is very little chance that this person with Prader-Willi syndrome is going to lead a healthy, full, and happy life. We did have families that said, you know, what good is it for them to live if they can't have access to food? We want them to be happy. And we've talked with families and with patients about the fact that dying from Prader-Willi syndrome, from these obesity-related complications, it's not an easy death. It's a slow, painful death, often precipitated by massive fluid overload, heart failure, inability to care for oneself, skin wounds from folds, under fatty areas on the body, inability to really do anything for oneself. And to see a 10-year-old in that condition, and obviously a 10-year-old would not, have that decision making authority in most cases, but even to see a young adult in that situation is heartbreaking, especially when we have seen and we know that with food security or food restriction that they can lose weight and they can still be happy and healthy. There's also the ethical value of non-maleficence. So we don't want to create harm, but there's different kinds of harm. So there's obviously the harm of not food locking and letting people get so ill that they often will die early if their obesity is not kept in check. But there's also non-maleficence when it comes to not causing undue harm from an emotional standpoint by locking food and not giving people that autonomy to make that decision for themselves. Like I said, I would not respond well to somebody coming into my home and locking up my food, and I don't think that anybody has a right to do that. So it makes it very difficult when you're working in this environment to make those recommendations. But I think that brings us to the next ethical value of veracity, and that is making sure that we are being very truthful with the person with Prader-Willi syndrome, being very truthful with ourselves about whether or not this person truly is able to understand the risks versus the benefits of having food security, and making sure that we're addressing those issues with people. And I even think that it's important, and I'm talking about people with normal to average IQs, but even for our persons with mild to moderate intellectual disability, they still have rights as well. So there are plenty of people who have other disorders. Another syndrome I can think about is people with Down syndrome. A lot of them suffer from obesity, again, due to kind of body phenotype and those sorts of things, and food lacking is not a recommendation for them. So it's not that people with mild to moderate intellectual disability don't have any rights, but I feel personally more comfortable in making the recommendation for food locking for people who are really not able to understand the extreme consequences of those food-seeking behaviors that we see in people with. They express a lot of sadness over how they look and their desire to be thin and their desire to do things like go to college. We had quite a few people who had normal intellect with Prader-Willi syndrome who did go to college, who had lived at home with their parents and became so overweight and so sick within their first year that they had to drop out of school due to their health issues. And the person being aware of the complications up to and including, having an early death. So I think also we need to be able to explain food locking and the ability for a person to have input into their diet for those who don't meet the above criteria of having a normal intellect. So again, just because a person has low or moderate intellectual disability doesn't mean that they should have no say-so whatsoever into their diet. But it is a very controversial issue, even in the Prader-Willi syndrome community. We do see in some group homes when food restrictions are relaxed, we see increase in anxiety, increase in behavioral issues, decrease in health issues, and it comes to mind a specific patient that I worked with from Canada who was a young man of average intellect. And when he went home, he absolutely put his foot down. They did have an ethics consultation, and it was agreed that he would be able to do what he wanted. And he said that he didn't care. He didn't want to live a long life if that meant that he would have to have food locked and have food restriction. And this person, he had been a patient on our unit several times, was very difficult on the unit, did not want to be there because he was from Canada and his parents had medical power of attorney. They wouldn't come and get him. So that there was a lot of ethical issues surrounding that as well. But he eventually opted for, and I was shocked, I spoke with his family a few years after his last admission. They called me to update me. He had actually chosen physician-assisted suicide in Canada due to his extreme obesity as a result of being able to live his life. Now, his parents told me that at the end, whenever the doctor came, they came to his house, that he said he did not regret the fact that his life was going to be ending early, that he had enjoyed the past few years, and I think it was just about 3 years, that he was able to have unlimited access to food and do what he wanted. Of note, he did not die from a stomach rupture, and he did have physician-assisted suicide. So I was stunned when they told me that, but it really gave me pause and made me think about what we impose upon others in the name of helping them. And I think it's a very sticky situation, and I think that we really have to look at the ethical implications of that and have ethical consults if there's any question whatsoever as to whether or not that's the right thing to do. And we need to include the patients regardless of their intellect. And of course, that would also, we would need to take into consideration their age. So in conclusion, the prevention of severe morbid obesity and early death is really the sole reason for advocating for food blocking for persons with Prader-Willi syndrome. So it really does come from a place of beneficence. I do believe the persons with Prader-Willi syndrome who have quote-unquote normal functioning intellect should be offered the support of a food-secure environment, but ultimately have the ability to choose if that's what they want. I think there needs to be a lot of education, not only for the person with Prader-Willi syndrome, but also for their family. Maybe some guidelines in place to say, if we'll have unlimited food access, but if you get to this weight or your health deteriorates this much, these are the resources that would be available to you. And again, ethical consultation should be initiated when the risk-benefit of food blocking is not clear based on the person with Prader-Willi syndrome's intellectual capability. So, really, again, speaking to autonomy and bringing that patient into that decision-making process, being truthful with them, and making sure that we are checking ourselves and having those ethical consultations and getting outside opinion. Prader-Willi syndrome is a very interesting medical condition. When I worked at the Children's Institute, when we had our inpatient program, there was a documentary filmed at the Children's Institute called My Deadly Appetite, and you can find that in its entirety on YouTube, and the Discovery Channel filmed that. So it's a really excellent documentary if anybody is interested in watching. So thank you for listening to my presentation, and I hope you all learned something about Prader-Willi syndrome.